Welcome back to Mastering Change. Today we're talking about something that often goes unnoticed, but has a profound impact on our lives. What happens in the first moments after birth and how those early experiences shape our mental and physical well-being.
Our guest is Jaclyn Ruggiero, a neonatologist and trauma researcher who spent years studying the long-term effects of neonatal care, parental resilience and early life stress. She's here to shed light on what we often don't consider, how the neonatal intensive care unit, also known as the NICU experience, affects not just babies, but their families too.
We'll be talking about the challenges parents face in neonatal units, the importance of skin-to-skin contact, and what hospitals could be doing differently to support both newborns and their caregivers.
This conversation is an important one, especially for anyone who's been through a NICU experience, knows someone who has, or just wants to better understand how our earliest days shape us. Jackie Ruggiero, it's a pleasure to welcome you to our podcast today. Thank you for joining us.
Thank you very much for having me. Hi.
So, as our listeners will know, we start all of these podcasts with a little card game that's called Where Should We Begin? I will just read the first card. Here says, an experience that shaped who I am that few people know about.
Oh, wow. Well, there are several experiences I think that have shaped who I am. Some very well known, and I guess I'd have to think a little harder about what's not known. But one of the big things, and this is known, is being a twin. I have a twin sister, and growing up with someone by my side was different than a lot of people, unless you're a twin yourself. And having someone always with me, but different at the same time, really highlighted strengths and weaknesses for me, and also kind of was a built-in rock for me. Didn't come without its ups and downs, of course, but that is one of the things to this day. Having a twin sister in the world is an incredibly powerful part of who I am and where I've gotten to go. Thinking about what people don't know.
I mean, I think our audience wouldn't know that anyway, so we can kind of say that was their
Okay.
Yeah, really kind of really nice insight actually into what it must be like. I'm actually quite jealous. I wish I had a twin, to be honest. It would have been really nice.
Having those shared experiences so that you can kind of look at those experiences through somebody else who is different but is on the same path. I hadn't thought about that as part of the twin experience, but actually in a world with increasing loneliness and isolation, having that connection from conception right through.
I think about it, and my twin and I couldn't be more different. We are really polar opposites in every sense. And so growing up, of course, there's a lot of friction with any siblings, but there was a competition, but then there was a lack of competition, because it wasn't the older sibling or the younger sibling on different playing fields, different ages, different activities. We were all in the same all on the same playing field. It's just where we excelled and how we saw the world was so different, which is incredibly interesting now as a neonatologist. And I take care of babies and interact with families and do the work that I do on a daily basis. For so many reasons, I've come into the field of studying trauma and mental health. But when I look at these babies, rooted in my own experience, it's really kind of an astounding thing to think, who are we creating and how is this impacting who you're going to be in the world, little one? Let's get you through this and let's get you reunited with your family, because there's so much more to come. We were also premature, and so, but not quite as premature as, your 25-week family member that you spoke of earlier. But there is that component. And so when I consider the babies I take care of and reflect on what I get to do, again, it's just so profound considering where are you going in life, little one, and, what is this going to be for you, and how do we mitigate some of what's going on here so that you can grow up and be the best you in the world.
I'm fascinated by that, and what I'm really fascinated by this, that sort of statement that you said, or question, I guess, was as how can we mitigate what's going on here so that you can be the best that you can in the world? How? How? I mean, I'm fascinated because my sister has 4 children. She had 4 under 5, and all of them were premature, and I'm petrified. For two of them were very premature, and 2 of them were less premature, but still all of them. And I just know already I can see things that are happening in terms of behaviors in 2 of them. So I'd be really interested to know, how do you mitigate some of what is being seen in premature?
And I'm just going to clarify, my sister's daughter wasn't born at 25 weeks. They found out in womb about the condition at 20. And so was born later, but the consequence then, it was the care after the birth because of the illness. So it's the same principle. That's why I think this idea of what can we do to get you into the optimal state if you haven't had the optimal, arrival.
Yeah, that's kind of where this part of my journey began. It was about 2018, 2019. I attended my first trauma conference, the international conference in Boston. And that's kind of when I opened up, and my whole world kind of opened up to the guest speakers there, the luminaries, and that's where the journey began for me. And having been in neonatology for several years at that point, practicing mainstream medicine, Western medicine, it really kind of shed a whole new light and sent me kind of spinning in some ways of, oh my gosh, how do I even begin to wrap my brain around this, begin to understand it, integrate it into my own practice, and tell the world around me, hey, we need to be doing this. We need to be thinking about this. We need to, as we're saving this life, in the same moment, be considering how are they experiencing the world. And so it ignited a lot of passion in me. And I've been studying and following conferences and a lot of these speakers for the last 6-7 years, trying to really understand that and continue to deepen my understanding and practice around these principles. And so how do we mitigate stressors in the NICU? How do we improve short and long-term outcomes? How, where do we even begin with all of that? And like I said, it was overwhelming at first for me of, oh gosh, I have to do this work, and how do I do it? Well, that's too much for one person, right? And so I started a little bit slower, back down, and thought about what are the essential practices that are going on in the NICU? What are the things that we do? What do we do well? And how do we start to highlight those and look at them to see how, how they're actually going on in our NICU and then in other NICUs. And so that's kind of where I started. I do a lot of work in kangaroo care. I've started to do some projects around parental resilience. And a lot of the work that we've been looking at over the last 4 years has helped to inform things that we already kind of know. Skin to skin, all of its stabilizing physiologic properties. It's linked to breast milk production and provision of breast milk from the mom. Mother and father's stability and ability to even be present at the bedside with their babies, participate in care, have a regular schedule and routine around these things. I mean, again, it all sounds very basic and obvious, but when you step back again and you start to do projects around what is happening, you realize a lot of the things that can be happening that are very basic aren't happening. And so my work kind of delved into what are the barriers? What is going on here that is in the way of this mother and baby being together, regardless of how sick the baby is, how young the baby is, whether the baby's ready for milk or not, milk through a bottle or not through a bottle. But what are the barriers? And if we can start to identify those with the baby, with the mother, and with the space in between, then we are one step closer to mitigating the impact of stress on the brain, the impact of the trauma on the developing brain.
And I think there's a couple of things that as I'm thinking about that, there's the team that is working in that context who you can educate and put those kind of procedures into place, that best practice into place. But at the same time, you've got the parents, and unfortunately, I think, especially in this country, prenatal just understanding of what the best practices are to start that journey of secure attachment from conception, but especially post birth, is not really well known. And in the case of these babies that are born in these difficult situations and too early, the parents are grappling with all of this new knowledge and this new education. So they need to have their hands held because this is all new. The whole environment is new. And so education around best practice needs to be, I guess, ingrained somehow in the care for their child. That it's a holistic piece, isn't it? Because for your team, you can just slowly iterate and get better and better. But for the people at the heart of this, at the center of it, they're key for that secure. Everything you're talking about is around attachment and physical development.
And I'm imagining the barriers. When you sort of mentioned one of the barriers to that, to happening, to what, and kind of as you were saying, sounds so simple. I find, to be totally honest, I find a lot of the answers within this field are the most simple ones. Whether we're looking at adult mental health or whether we're looking at anything, it's often, things like, well, but on a different type, like sleep hygiene, movement, what you eat, all of that kind of stuff for an adult to look after themselves. So when you said, it's simple things like skin to skin and all these other things that should be happening, being present with your baby, being by the side of your baby, being with your baby, they are simple, but those things often don't happen. And I'm interested in what you found were the barriers to those things.
It's fascinating. So, for example, in one of our studies, we looked at medical characteristics of infants, and we separated them into 3 different subgroups: our really small babies, the less than 28 weekers, our 28 to 34 weekers, and those were subdivided into 2 groups just because of medical complexity. And what we found was that in our very small babies, one of the biggest barriers was a certain kind of central line that we call a peripherally inserted central line, a PIC line. And when we saw that, I said, well, that's pretty interesting for me, because most neonatologists would not look at any baby and say that a PIC line is a reason to not do skin to skin. So when you think about absolute contraindications, there's about 4 or 5 absolute contraindications that I would look at you and say, no, you cannot do skin to skin. The baby may not even be able to come out of the isolette or the incubator with this particular thing going on. A PIC line is never one of them. In combination with, for example, being on blood pressure medication that's keeping the baby's heart going, yes, but not by itself. And so, as an example, as a barrier to care, when I saw that, I said, wow, this is we really need to do some work here, because a PIC line by itself is preventing this mother from doing skin to skin with our baby, and that shouldn't be the case.
But who was saying that the PIC line was the barrier, the mother or the neonatal unit?
Oh, the data. So when we went through all of our babies, and we looked at the medical characteristics present on the day that the baby could do its first skin-to-skin experience with the mother, we looked at, for statistical significance, the number of babies that had different medical characteristics, whether they were or the breathing tube, whether they were on blood pressure medicine, whether they had different kinds of central lines or not, all these different things. And so we looked at it on the day that they could first perform their first potential day for skin-to-skin care compared to the day they actually did skin-to-skin care. And when we looked at the 2 different dates, we found that the babies had a higher number of babies had those PIC lines present on the day that they could first potentially be doing skin to skin with their families, but weren't. And so we saw that those babies were getting the skin to skin on the day of first. Yeah. So when they finally did do it, that was the thing that was not there anymore. And so that's how we kind of assessed it. I'm not sure if I explained that well, but that's how we looked at it. And so we were trying to tease out what was present and what was not present, what changed, that the skin-to-skin experience could actually happen, and that was the biggest one, and I said, "Oh my gosh, that shouldn't be happening."
Did you find out whether it was a parent was like, "A baby's got a PICC line and I don't feel comfortable or safe holding my baby now because of this PICC line," or was it the neonatal unit saying, "Oh, don't touch the baby because it's got a PICC line," and that's the kind of the question I was asking.
I see, and I wish I could answer that. That I do not know. Unfortunately, with different institutional review board approvals and whatnot, getting permission to call the families would have been very complicated. In this particular study, it was only a 10-week study. And then the second thing is bias recall. I'm not sure, unless we prepped the families and explained to them what different things are, I don't know if they would be able to pick up on,
Yeah.
I was afraid of just this one thing. They may, some families are savvy enough and said, I was afraid of this. Most people, when I talk to them just anecdotally, are afraid of the experience. And so getting into, it's kind of almost like being a therapist in a way, of having that continuum, that rapport, and continuing to have the conversation around what's going on with a family, with their baby, with the experience. And I get that when I'm taking care of a baby longer term, I start to learn a family, and I eventually get to the point of, oh, this is what's going on for you, and this is what's happening. I'm not quite sure, outside of maybe a questionnaire, if we're really going to be able to tag that in the moment.
Would the solution then be, if you didn't know whether it was the parents that were afraid or the neonatal unit saying don't touch the baby because of the PIC, would the solution be to educate parents and neonatal units that a PIC line is not a barrier? It should not be. Any child with a PIC line is perfectly safe to be handled and to be touched and to be held.
I would imagine, though, there's just this implicit, it's a vulnerability, isn't it? It's like anything that when visible vulnerabilities make people, I mean, I would be really fascinated to understand. I mean, that is a big study. It would be a difficult thing to really understand, but what are those kind of, what is it that's making that play out? Because I do think there is a deep, for these parents, a deep psychological, you know, understanding that it's really important to work through your own psychological barriers or fears because of the value of the contribution, holding their hand through that journey because of the long-term value to that child in their own development, for you overcoming that fear. Because there's two things happening, isn't there? There's the child, but the child is so reliant on the parent and that attachment and that nurturing and that feeding from the mother. The research is in abundance, the value of those things in constructive development. I, yeah, I'm really interested in the care for the baby and versus the care for the parents as well.
Yes. Well, and let me respond to Araminta's comment earlier, or our last comment. We did the following year, which was 2023 summer, we started a quality improvement project around exactly what you were mentioning, education of healthcare providers. And so what we did was, our intervention was essentially an education bundle that targeted nurses, doctors, nurse practitioners, our trainees, residents, fellows, all of the different people. And not to go through all the details, but we created an education bundle about contraindications to kangaroo care. What is kangaroo care? Because everyone thinks they know, but it's nice to revisit the material. And so we dispersed all of this through email, flyers in the restroom, all high traffic area. We did bedside signage. We had our student going around every day to every baby enrolled, which was pretty much all our preemies, to remind the bedside nurses, hey, this baby can do kangaroo care. Hey, this baby can do kangaroo care. Unfortunately, because again of study approval, they couldn't interact with the parents. It becomes complicated with vulnerable populations. But we did do that. And over the 10-week course that we had our student, kangaroo care rates actually doubled. We went from 26 to 52% kangaroo care in that particular cohort. Again, it was only a 10-week period. We also saw more than doubling of our EBM, express breast milk provision for those babies, both during hospital stay. It was a yes, no, yes received or didn't. So during hospital stay and during hospital stay to discharge. And so the numbers were very clear, statistical significance across the board. The following summer, which was this past summer of 2024, we did basically the same project, except we focused on the parents. And so we just switched our spotlight to a different stakeholder. And so we looked at the parents alone. We did the same routine. We actually randomized across the preemie cohorts to visit with a neonatologist or study team member or not get anything at all, just the standard flyby. Maybe the nurse mentions it, maybe the doctors mention it, maybe they don't, which is kind of how it goes in a busy unit. And so the families that were randomized to meet with us and to receive this education bundle with us, we didn't see any difference at all. And it was pretty defeating, honestly, at face value. And I sat back, I had a cup of coffee and thought about it. And I said, well, how profound if you really kind of big picture this. We don't make a difference unless our system, unless our hospital, unless our providers have buy-in. And I thought it was fascinating because I thought, the number one stakeholder is going to be the parent. And if the parent believes in it, it's gonna fly. And it was not the case. We didn't see any change until you had the buy-in from the providers. And then the other interesting thing to that was because we did see statistical significance and a doubling of rates in the summer previous to the parent education bundle, for there to be no significance at all means that also went away. Baseline, that had to have gone away for there to be no significance. And then on top of it, with our education bundle for the parents, we didn't regain that statistical significance. So it just speaks volumes to we need to get the information to the providers. We as a system, as therapists, as social workers, as doctors, as psychologists, as our whole group, our speech therapists, everybody we need multidisciplinary approach to bring everyone together to buy into this concept of relational health as a way to mitigate trauma in a stressful situation, which these babies are committed to for months.
So when you did the second study, you went back down to the previous year's baseline, then you didn't, because wouldn't the baseline have risen to the doubling of the kangaroo care? Wouldn't it have it went from 26 to 52, whatever you said it was? Would it not have stayed at 52? And then to see no increase would be from the 52 as the baseline or not? You went back down to the 26.
Yeah,
oh.
Roughly. And that was again, one of the defeating points was, wow, if we are not, like I had my student every day going around revisiting.
That's what happened. Yeah, that's crazy. That is really escaping.
That's a busy NICU. And I think it's, it's here, it's in the UK, it's in Europe, it's across the world. We are so busy and inundated as a system. We're stressed out. Families are stressed out. Babies are going through this life-saving medical treatment, except this is all disconnected and fragmented. And so,
you just said it as well. You're stressed out. The babies are stressed out. Everyone's stressed out. So you're the whole environment. The parents are stressed because they think their baby's at risk of dying or whatever, etc., etc. You guys are stressed out because you've got busy schedules. There's loads of babies to look after. There's not enough time to sleep and eat and look after yourselves. The environment in general in hospitals is just not conducive to recovery in my mind, full stop. And that's a whole nother quest. That's a whole nother thing. But you kind of said it there, is the system needs to change. And that's everything, to the fact that there's not enough windows in a hospital, to the fact there's not enough, I don't know, so many things around hospitals, but
nutrition, everything, like this, that.
Yeah, like, it's a really self-important thing though, because I just need to know this question because it's going to annoy me. What is kangaroo care?
Right. So kangaroo care is skin to skin. It's holding the baby in an upright, usually reclined position where the bare chest of the parent is touching the bare chest of the baby. And so they basically are essentially laying in a reclined position, just skin to skin, typically a blanket or a wrap around the baby, some blankets, some pillows to support the parent. But it essentially comes from the whole concept of a Joey and its mom kind of in that pouch, creating that safe space, that micro environment of nurture, connection, love. But
Well,
different than holding a baby, say, wrapped, that skin to skin touch, that connection, the activation of the autonomics, all of the things create a space of cardiorespiratory stability, temperature regulation, all these different physiologic parameters that are very different than being held in a blanket.
yeah, no, I mean, we just actually said yesterday, both Emma and I are wearing Aura rings at the moment, and I've been doing a little test on with my own biometrics of how my heart rate changes when I hug my son. And I specifically, I very much like to hug my son with skin to skin. So when I do it often, Emma, by the way, one thing I didn't mention yesterday was that it's often skin to skin. And especially when I hug him skin to skin, my heart rate just drop, like literally can be at 100 or 80 or something quite high and go down to low 60s or below, and it's really, I love doing that test. I do it most days
Oh, it's
whenever.
co-regulation in a nutshell. That's
Yeah.
that's what that is. And Emma, you were mentioning just before we got into this dialogue about the parent part, about hand holding parents and walking them through, and it speaks to exactly what Araminta's bringing up, which is, if you don't have an available caregiver, and I'm not talking about the provider, I'm talking about the mom, the dad, the other mom, whomever are the primary caretakers, if they are not present, then that whole bit of co-regulation goes away. It's not available to the baby. So the parents are shaping their baby's brains. They, especially these 22 to 24 weekers that come out, whose limbic systems haven't even begun to develop, which is responsible for emotional regulation and ability to be in the world and all of these sorts of things around meaning making and experiences. So the parents are critical, and we've got to figure out how to get them there more consistently, less scared to participate, and then in a space of regulations that they can co-regulate with their baby, because it affects emotional availability, it affects the ability to bond. Parental trauma is a barrier to being able to bond, and exacerbates, like you said, those feelings of shame and guilt. And so when you're in that headspace, you're not available to what's in front of you. And so there's so much that has to go into that in order to create this one-on-one or this safe space for co-regulation to exist. And
I,
that's where we mitigate trauma.
you give away control in that situation. You're medicalizing something because it has to be medicalized for survival. But you don't. I guess there's a feeling, and the study that you did last summer, is like the control is not with me. So you can do you know what I mean? Like because it's so profoundly technical and medicalized and systemized, and there's all the experts around, forgetting that the expert that matters most in that long-term development of the child is that of the parent and their role in that child's life. But there is this thing of feeling out of control, I guess, when you can't be the one to take that. And the only way I can relate to that is that prior to working in this space, when I had my children, the system had taught me so much about birth being this horrendous thing that women have to do. I decided I was going to go for an elective section and hand that control over to someone else, until I had an incredible consultant who, long story short, I hypnobirthed both my children with nothing. But if I hadn't have had that experience, the kind of system had told me that this was awful and I needed to, you know, big career, I wasn't in control of this. I needed to hand the control over to an expert that would do it for me. And I think that state of mind, particularly in that profound moment of need, where without that expert, without that control, there is no future. But knowing that your role in it is as profoundly important as the clinician's role in it, I think that feels like that understanding with that parent is maybe not there.
There's one story that it broke my heart. I went to the bedside to talk to the nurse about some orders we were writing for a baby, and she was distressed about her interaction with the mother. And, so what happened? And she said, the mother told me that she doesn't feel like this is her baby. She doesn't feel like the mom. She feels like is completely incapable of taking care of her baby. And she feels like the nurse, who is the primary nurse, they pick up primary patients. She said, I feel like you're my baby's mother, and I'm not. And I mean, it just brings in so much, because on some levels, like, well, medically, no, you can't take care of this baby. That's why we're here. This is our job. But there was clearly a disconnect. And how do we bring families back in? And I look at ever since then, part of my rhetoric has become, inappropriate. This is your baby. This is not my baby. Your baby will be with me for whatever period of time. I can help your baby, but this is your baby. He or she is your baby. I'm part of. We're a team. You're a critical part of this team, and you may not know a whole lot of how to interact or what to do in the beginning when the baby is 23 weeks and you can't do skin to skin and you can't do certain things just yet. And maybe it's 10 days, maybe it's 20 days. I have no way of knowing. But as we continue to hit milestones, there's going to be more and more that you can do. And point blank, giving breast milk is that's so much right there. So these, like we were talking about, these little simple things are big deals, and we've got to get that across to families. Of number one, you're incredibly important to this team. You're central to your baby's world, and we need to create a space where you can be present and do, even if it's just this one little thing. We'll write down one goal, 3 goals, whatever it is that you feel comfortable with, not more overwhelmed, but supported with. But how do we do that? How do we bring that to the bedside consistently?
And give them some power back. Give them
Mhm.
something they can do in that situation, because it's really fascinating that the research from the study last summer.
But I just have a question, because this is more of a kind of, again, personal, relating back to my sister's experience, but it's going to relate to so many people who have had children during COVID, when the obviously the hospitals were shut down. So my sister had 2 children during COVID times. One in particular was when it was absolutely no visitors. Her husband couldn't go in. All of the staff were in hazmat suits. She was really, really unwell. The baby was separated from her. She was in hospital for 8 weeks, I think, and the baby too, not together. What happens in that situation when I mean, the repercussions I'm sure we're going to see in traumatized children going forward, but how were things mitigated then? And yeah.
I think the whole world obviously was all thrown into something that we had never experienced before, and nobody really knew what to do. We all tried to, you know, get it together and figure out the next best thing to do, but we had no precedent to go by of how do you do this. I remember talking to a 25-week mom who was admitted and hoping not to deliver her baby. They were slowing down her labor, and I went to visit with her because also her husband couldn't come in when she was on antepartum. Dads could come in if they were specifically in labor. And then once the baby was born, they had about an hour, then they had to leave. So it was a very limited experience. It's heartbreaking for a lot of people. But I remember this particular mother saying to me, I don't know what to pray for to not have my baby, but that means I'm separated from my husband indefinitely from 25 weeks till whenever I deliver, or pray to have my family reunited, but that means that the baby's here. Because we did allow families into the NICU, parents, but it was very limited. So, I felt it as well. Uh, we honestly did the best we could. We couldn't regulate the obstetric ward, the antepartum, postpartum. We really didn't have a say from that standpoint. But from the baby standpoint, we continued to do what we always did. Any delivery, once the baby goes in the transport incubator, before they go up to the NICU, we always show those babies to the mom. and dad if he's in the room and available. But the families always see their baby before they leave the delivery room, whether it's the C-section operating room or the usual labor and delivery room. So we were able to continue doing that, because the baby's in the incubator. So there was no problems with that. We were allowed to have the families, the moms and the dads come in. Grandparents, of course, couldn't come. Siblings certainly weren't allowed. But mom and dad could switch off at the bedside, and there were no restrictions to the time and hours that they could spend. There was just a very heightened awareness around hand hygiene and wearing the little smocks. And, there's a lot more diligence, masks and things like that. Eventually, we got to where families, mom and dad could come back together, but that became, more of the exception up front than the rule. For our very sick babies, we certainly made exceptions. They were case by case, and the managers, it was very humanized in that sense. Any baby that was dying, there was no restriction around that. We just made things happen. It's basically comes down to good-heartedness. And what do we need to do that makes sense, that isn't going to break the rules, that isn't going to cause any harm to the other families and babies. So we were able to do things like that. Of course, we had our FaceTime and our virtual kind of things. We do scent cloths. And so the mother's breast milk on a scent cloth, we could bring that in, put that in the incubator. We encouraged music, talking, make a recording for your baby and they can listen to that over and over. Anything repetitive or ritualistic based is or ritual based is very helpful for the auditory and the nervous system. So we just tried to find creative ways to keep that thread, because it all matters.
Yeah, it's really great that you can employ that much creativity. It sounds like what's missing is a bit of a protocol that it comes from the work that you've done, the insight that you have, and the implementation of some of the practices, the benefit of that you've seen. I'm would love to see that implemented, because I think when we start to understand the earlier those interventions, the more we can mitigate the consequences of that for everybody involved. We are moving towards preventative health measures, but they need to be sort of systemized into all aspects. And because in those critical situations, it's not the first priority, stabilization, but yeah, I think a protocol sounds like it's in needed.
Yes, and that's what I'm working on. This is 4 years now of working with Kangaroo Care. Like I said in the beginning, it was descriptive data, kind of trying to identify what are the barriers to quality improvement projects around how does this help? Does it have an impact? Where are we getting the best impact? Do you combine it? Where do you go with that? And so I'm working with our nursing managers to try to instill a new protocol around Kangaroo Care so that we're not missing it, because nobody's malintended. It's just, as we were talking earlier, people are busy. There's a lot going on. We're saving babies at 22 weeks now, whereas what used to be 24. We're saving babies with very different congenital anomalies. We're doing in utero surgeries. There's so many more things that are going on now versus, say, 10 years ago, that make the landscape difficult to navigate at times. And so we don't mean to, but we forget those basic things, kind of running out of the house and, oh, wait, where are my keys? Of course, I can't do anything without those. And so it's kind of getting back to getting some of these basic things on autopilot, and then doing what you all are doing and a lot of people in this whole network are doing, which is how do we address the mental health behind the scenes of how are we all doing? How are we doing as providers? How are we doing as a healthcare unit? How are we doing globally in our networks? But really, how are the parents doing? How is a new mom doing? How is a new preemie mom doing? How is a new mom doing who knows her baby's born with essentially a broken heart that can be palliated and corrected with surgeries, but never truly fixed? How are we doing? Because how the adults in all of this essentially are doing, whether they're a provider or a family member, is what's shaping how the baby's brain is developing and how they're going to do, because it's that relational health that is at the core. It's the framework for how they relate and navigate in the world. It's early relational health is what builds resilience. It doesn't mean bad things aren't going to happen. It doesn't mean that life isn't going to be hard, but how do I approach it? How do I face it? How do I take it on? And that's, I think, what we're talking about, is not to make all the bad things go away. Hey, we're never going to make prematurity go away, but how do we equip ourselves as providers and families to face it together, and to do it with the best peace of mind, knowing that we took this on and it may not come out perfect. It may not be what we thought, but we're building that internal resilience, and then that baby is getting that from us.
You kind of mentioned the system, and you obviously have the system that works within that unit, but then there's obviously the kind of ongoing care. That baby has had those experiences from birth. What's so important then is that it's continued ongoing and matched up. And do you have a system now that people report back into you, or is it once they leave your care, you kind of put it off in the world and hope that the system isn't broken once it goes out there? Because yeah, what happens then?
Yeah, you're hitting on my heart now. It's so we do, most major medical centers have what we call a high risk or follow-up clinic for high risk babies. And so they follow for usually the first 24 months of life, because we tell any family babies born early should catch up to their counterpart term their term counterparts that were born the same day within about 24 months, depending on how young those babies were. So our high-risk clinic is wonderful. They have very high rates and very high successes. A lot of institutions, the neonatologists run that. Here we have pediatricians that worked in the NICU that run that for us. I love that you brought it up, because this year I'm just starting, actually last week, I started to write up the proposals, and I'm onboarding another student to work with me. We're going to try to start to link the inpatient to the outpatient, because we have this very rich not fetal center, high risk clinic. We have a very high rate, one of the highest rates of follow-up and compliance. And so I've been emailing with them actually just the last 2 days. We're going to start to try to link kangaroo care as the inpatient variable. I mean, we're watering this down, right? We're just going to look at 2 variables just to start the link, because there's so much to think about. But the inpatient variable is going to be kangaroo care, yes or no. And the outpatient variable is going to be our Bailey score, which is that's the major thing that we follow in the US. I'm not sure about abroad, but the Bailey score for neurodevelopment, for motor development at 22 months. And we're going to try to figure out how many patients we have in common that have followed up in the clinic that they have the scores for. The unfortunate part is we all just changed our computer system, so we've got to locate all these babies. That's what I mean by we got to try to match up our lists and try to optimize the number. But that's what we're going to start to look at, hopefully this coming year. The other things I'd like to look at, if we have time, or head circumference to speak to brain development, growth velocity, how well is the baby growing? Are we still giving breast milk up to 12 months or beyond? Different parameters. Was the baby referred to speech pathology, yes or no? Did the baby have feeding difficulties beyond, yes or no? And just starting to kind of create a framework for understanding how did the babies do, because again, that's the thing. I'm walking around thinking, okay, my new 24-week baby just got to the unit. Who are we creating? My immediate thought is, who are we creating? What are we doing? And how are they going to do when they're out of here, right? And that's what the families want to know. And so I'm
And
trying
then
to.
also, what are those early interventions? So let's say there is things on those scores that you mark down that aren't quite where they should be. What can be done then to make sure that you are then mitigating the possible so much earlier than perhaps noticing a child at age 7, 8, 9 when they've got serious dysfunctional behaviors happening. I think it's fascinating. I think it's so important and could really, yeah. I mean, I really hope that the work that you're doing gets out there, because yeah, the most important at the earliest stage, isn't it? Really.
I mean, I'm only as strong as the network. And I came on to the great fortune of meeting a mentor who put me in touch with the Early Relational Health Fellowship at UMass Chan Medical School under Ed Tronick, who's linked to a lot of the luminaries at the Oxford conference. And working with him over the last
Ed,
few.
unbelievable. Yeah, I was going to say, I hope you know Ed, because I think there's
Oh gosh, yes. He's my program director, and I'm hoping that we can
oh,
collaborate on some depression studies. I'm trying to figure out, because remember, in all of this, I'm full-time clinical. I have no research time. So this is all my spare time. It's my hobby.
wow.
But we're trying to figure out how to do, we've been emailing depression studies and loneliness studies, speaking to the Surgeon General's report on loneliness, especially since COVID, all these things. And how do we start to study this in real time, and, tease out all the confounders and biases, but taking on that fellowship and getting the certificate with that program was instrumental for me and has opened a lot. It's the reason why I met your group. It's why I went to Oxford through Edtronic. So it's been an incredible journey from that standpoint. And then through that program, actually, I was put in touch with the people at Brown University, and I'm being in the program currently to get certified in a specific validated tool that does, on the inpatient side, look for deficits, cognitive, motor deficits in our babies. It's a predictive model to predict that a baby will have social issues or cognitive issues or motor issues or whatnot, so that we can do targeted therapies in the unit to optimize outpatient outcomes. So, that we're getting into a little gray area. Do my colleagues have buy-in with that? Do they want to implement it? What am I allowed to do? What am I not allowed to do? And then the biggest thing, of course, is if they're going to let me do it and use resources to use this tool and follow our babies inpatient, how is it being followed up outpatient? And so that's obvious. I mean, nobody's going to pour resources into something that's not being followed on the back end. But that's, again, why we're going to study what we're studying this summer, to kind of show some link, and then hopefully continue to fill in the chicken wire and just keep filling things in until we have more and more support.
We live in a climate of a lot of fear and anxiety and doubt at a macro level, geopolitical, environmental, loneliness. We talked about the individuals, how they relate to one another, the demise of community and society. It's hard, it's difficult. If there was a single lever for change that you could pull, a single button you could press to create the change that we need to see in the world, what would that be?
Wow. I mean, it all starts with trust. It all gets into epistemic trust, I believe. There's no way to create that kind of connection and lift that veil of doubt without leaning into some epistemic trust, some belief that I've got you and you've got me, and it's for the right reasons, for auspicious reasons, that I am here to walk my dharma, and you're truly aligned with that, and in support of that you want to see me do well, and I want to see you do well, that it's not about dollars, that it's not about, some check on my CV, or I got to write that paper, or, that we're a little bit less self-centered and a little bit more outward focused in that sense, that when we are coming into self, it's in a space of reflection and less of me, mine, I want, I need. So I think that that's at the core of it, is that epistemic trust of how do I create a place for myself and for others to really lean into this place where we believe that there's moral standing, and that we really want the highest and best for our babies, for our families, for one another.
It's been a pleasure to have you today. I've really enjoyed the conversation. I'm going to be watching with absolute fascination and intrigue as you develop your body of work and your perspective and point of view on this really important subject matter. So thank you for being so generous with your time and your ideas. And I'll look forward to welcoming you, I'm sure, at one of our events or in another capacity soon. Thank you.
Thank you. This has been an absolute honor and pleasure, and I'm so grateful for the opportunity. Really, really incredible, unique experience. Thank you.